Remsa's Blueprint for NIH Success in Achieving the Triple Aim. How Remsa's community health program created a path to success and sustainability. Our presenter today will be Brenda Staffen, Chief Operating Officer of Integrated Services for the Regional EMS Authority in Reno, Nevada. Brenda has been recognized nationally for her leadership, expertise, and accomplishments in EMS. She's currently the Chief Operating Officer of Integrated Health and previously served as Director for Remsa's Community Health Programs and Healthcare Innovation Award Grant. She has worked in EMS for more than 3 decades, serving the American Ambulance Association, the California Ambulance Association, and as a Corporate Director with the Rural Metro Corporation. A couple quick notes before we begin today. This webinar will be available for viewing on demand once we complete it, so you'll get an email and be able to view it and go back to parts to watch again. In addition, we'll have a question and answer period at the conclusion of the presentation. However, please feel free to ask questions using the audience questions button at the top of your screen throughout the presentation. At the conclusion, we'll get to as many questions as we can. Without further ado, I'll turn things over to Brenda.
Thank you, Zach, and welcome to everybody on the phone today. Thank you very much to EMS1 for hosting this webinar, and also thank you to Keith Griffiths and the Red Flash group, including Michael Gerber and Susanna Smith, for their assistance in planning today's webinar. So as you know, Remsa has released a white paper with the outcomes and the independent evaluation of our community health programs. Today's goals are to provide an overview of our program and what were the essential components of our successful community health programs. As I mentioned, we're going to describe how we measured and evaluated our program effectiveness and also highlight some lessons learned. And finally, we will talk about the value proposition and what are the keys to sustaining system-wide change and achieving reimbursement. Remsa is a Healthcare Innovation Award grant recipient. We are one of 6 nationally that were awarded a Healthcare Innovation Award grant that either included paramedics, community paramedics, or were engaged with the EMS, the local EMS provider. And our grant was in round 1. There are 3 additional grants that are nearing their final grant year in round 2. Remsa is the primary ambulance transport provider in Washoe County, Nevada. We're a private nonprofit organization serving Northern Nevada and Northern California, celebrating our 35th year of service this year. In addition to our ground ambulance services and our community health programs, our sister company is CareFlight, our medical service with 4 bases throughout Northern Nevada and Northern California. We have very extensive community education and professional education, special operations teams, special events coverage, and a medical communications center. In fact, our company carries 5 national accreditations across those services. The most important aspect of planning a successful mobile integrated healthcare program, or as we call it in our community, a community health program, is how you take aim. This is based on the concept of the triple aim, founded by Dr. Donald Berwick, who was President Obama's first CMS administrator and the founder of the Institute of Healthcare Improvement. Triple aim means that healthcare services and healthcare service improvement are achieving improved quality and experience of care, improved health of the population, and reduced per capita costs. So all Healthcare Innovation Award grantees were required to measure and evaluate their programs according to this triple aim. For our program, we actually implemented 3 interventions, which were designed independently, but then became integrated and now in our 6th year of ongoing service delivery, are integrated into, again, what Remsa calls our community health programs. First that we launched in December of 2012 was Transport to Alternative Destination. We are transporting low acuity patients that do not require a visit to the emergency department to an alternative destination. This is condition-based, and so based on the condition of the patient when the ambulance arrives at the scene, they perform an advanced assessment and transport intoxicated patients directly to the detox center, behavioral health patients directly to 3 mental health hospitals, and low acuity patients directly to a number of urgent care centers and federally qualified healthcare clinics. We actually started with 4 alternative destinations when we launched, 1 in each category, and we have approximately 16 alternative destinations to date. I'm going to pause here and ask Zach if we're having a volume issue.
Hi, Brenda. Yeah, we're having a couple people having trouble hearing you. So I'm trying to troubleshoot here, but maybe just speak up just a little bit more.
Okay. Zach, can you hear me?
Yes, I can.
Okay. So I'm going to switch to an alternative method. And we did a sound check before, but as you know, there we go. I see a message that says that's much better. So
I think that's much better. Thank you.
Okay. I apologize to everyone. So that's a brief description of alternative destinations. Transports to the detoxification center, transports to mental health hospitals, and transports to urgent care centers and federally qualified healthcare clinics. Our community paramedicine intervention has 2 programs, a 30-day hospital readmission avoidance program, and then something we call evaluate and refer, which is where primary care physicians can contact the community paramedic in lieu of dialing 911 or sending the patient to the emergency department. We trained 10 paramedics, experienced paramedics with 150 hours of additional training. And all of our programs are protocol-driven and have extensive medical oversight and CQI follow-up. Our third intervention is the Remsa Nurse Healthline. Registered nurse navigators provide 24/7 access to assessment and triage of callers to an alternative location of care. There are 2 pathways to, it still looks like people are having a hard time hearing. So, Zach, if you want to give any advice, just let me know. Otherwise, I'll keep going.
Yeah, for sure. I'll sort of work on the audio issue with the audience, but I think that most people can hear you, so I would proceed and I'll work with audience members.
Thank you. So again, there are 2 ways to access the Nurse Healthline. The first way is we have now turned on what are called the Omega protocols in our emergency medical dispatch system. So when a 911 caller completes the protocol for pre-arrival instructions and it meets the Omega list of condition codes, the caller is asked for their consent to talk to a nurse, and we transfer the caller out of the medical communications 911 system and into the Remsa Nurse Healthline, where she has an additional algorithm to identify the location of care and the recommended level of care, which may include self-care at home, may include calling the doctor's office, making a doctor's appointment, going to an urgent care center, and at any time that the patient and caller identifies with a emergency medical condition, we can transfer the caller back into the 911 system. The second way that you can access the Nurse Health Line is a broadly communicated non-emergency number that the community can call directly. Same protocol, same process, a recommended level of care, and a recommended location of care. As I mentioned, we launched all three interventions separately and then began to integrate them. And we have some important lessons learned that are highlighted in our white paper. Medical director oversight and a very strong clinical quality assurance program are important features across all three of our programs. The most important lesson learned about the alternative destination is that our protocols were designed very conservatively. We created very strong collaboration with the receiving facilities, and we measured what we call the repatriation rate. Each time a patient that was transported to an alternative destination was transported back to the ED, we called that a repatriation transport. That happened only 4.7% of the time over the 4 years of the program. That means the paramedic in the field, following an advanced assessment, made a destination decision that was correct 95% of the time. I want to also make a comment about the connection between treat and no transport, treat and release, and treat and refer. It's a matter of sequence. In the Remsa intervention for alternative destination, because we wanted to assure no adverse events and we wanted to assure quality and collaboration among our receiving facilities, we are not doing treat and no transport, treat and release, or treat and refer. We are sticking with performing an advanced assessment and transporting to an alternative destination. When the healthcare delivery system is ready for those three additional sequenced interventions, we will consider them, but one of our strongest lessons learned is to start first with transport to an alternative destination. Our second intervention is the community paramedic intervention. As I mentioned, experienced paramedics received 150 hours of additional training, and the most important thing to emphasize here is that our protocols for community paramedic are within the existing scope of practice in an expanded role. The protocols were developed again by our medical director in collaboration with our referring clinical partners. They are evidence-based and diagnosis-specific. So in our hospital 30-day readmission program, we have a congestive heart failure protocol, COPD, post-MI, and post-cardiac surgery. So what's the connection between the paramedics and the referring primary care provider? Very strong, and all of our community paramedic interventions require the patient to have a primary provider. In fact, that's what the Evaluate and Refer program is intended to accomplish. So those paramedics are not responding to 911 calls, they're responding to referrals from the patient's primary care provider or referring physician. The third intervention is the Nurse Health Line, and there were important lessons learned there as well. Our nurse navigators are located in our fully integrated 911 Emergency Medical Dispatch Center. As you know, nurse triage and nurse advice is not a new concept. In fact, many national insurers have their own nurse advice call centers. As I mentioned, the navigators are using evidence-based protocols that are called Emergency Care Nurse System, and they are identifying the locations of care that are also closest to the caller's home and accept the caller's insurance. Call takers use these evidence-based protocols as a matter of the ECNS system. So how does the ECNS protocol, Emergency Care Nurse System protocol, compare to other nurse advice lines? Well, the most important distinction is that our system is nurse triage, nurse advice. And in fact, similar to that alternative destination repatriation rate, we transfer less than 2% of the calls from the nurse healthline back to the 911 system. That means callers are selecting the right location of care reliably, and the protocols are very precise. We're not getting high acuity patients talking to nurses. So that type of safety measure, the alternative destination repatriation rate, the nurse healthline transfer rate, those are both safety measures, are very important to assure no adverse outcomes and the quality and experience of care for patients. So now I'll summarize what our program outcomes are. The outcome domains were required by CMS Innovation Center, and we had very rigorous data collection protocols and procedures. We submitted data on a CMS website on a quarterly basis, delivered quarterly narrative progress reports, performed our own data analysis for the purpose of healthcare process improvement, and then also submitted the data to the independent evaluator, RTI International, which I'll discuss in a minute. So our outcome domains cross quality and safety measures, the patient's experience of care, utilization, and by reducing unnecessary utilization and referring patients to an alternative pathway of care, we're able to generate savings due to reduced utilization. I want to make a note about our measurement strategy. The Remsa self-monitoring data, again, was intended for an innovation project and healthcare improvement purposes. So we followed the IHI measurement for improvement. Then we also followed CMS Innovation Center and RTI International's requirements for measurement for research, and in this case, measurement for the purpose of identifying program savings. I'll talk later about RTI's methodology, which was intended to create comparison groups and then compare actual Medicare expenditures among patients that were enrolled in our program and patients with similar demographics that were not enrolled in our program. So over the 4 years of our program, which was July 1st of 2012 through June 30th of 2016, we were able to accomplish goals in all three triple aim quadrants. We improved access to quality of care and actually received over 63,000 calls to our Remsa Nurse Healthline. Over 1,500 patients were enrolled in our community paramedic program, either 30-day enrollment or the single visit, evaluate, and refer. And we transported nearly 1,400 patients to alternative destinations. We tracked patient satisfaction across all three interventions, and in our community paramedic program, we have data regarding the patient's perceived increase in their quality of life, and we also did competency testing. The University of Nevada, Reno did competency testing of our 150-hour community paramedic curriculum. All told, we saved $9.6 million over 4 years over grant expenditures of $9.1 million. So that means we saved every dollar that the government invested in our grant plus 7% return on investment. I'll describe our year 4 return on investment in the value proposition section. Of course, we achieved those savings by accomplishing avoided events, avoided ED visits, avoided ambulance transports, and avoided hospital admissions and readmissions. So this is the chart showing our grant expenditures in over the 4 years and total savings. So the calculation of the return on investment ratio is comparing grant expenditures to grant savings. This is an example of our patient satisfaction survey for the community paramedic program. the patients absolutely connected with our community paramedics and gave our paramedics outstanding satisfaction scores. This is a run chart which shows the readmission rate for congestive heart failure patients. We actually achieved a 37% reduction in hospital readmissions for CHF patients. That's all-cause, unplanned, 30-day readmissions, and it is all patients that were enrolled in our program. And we had that data not only validated across our program, but using hospital-specific internal readmission data as well. One of the most interesting findings in our program was the data that indicates all three interventions are targeted at the patient populations who need it the most. Prior to the launch of the Nurse Health Line, the University of Nevada, Reno identified for us the top 10 zip codes that had health disparities. And we direct mailed Nurse Health Line phone cards to those top 10 zip codes. What this chart shows is the Medicaid ED visits per 1,000 persons per year in a baseline year. So those are the first columns in this particular chart. Across the left-hand column are those data by zip code, and the yellow zip codes are the top 5 zip codes for health disparities in Washoe County, Nevada. There's also a baseline number for ED visits per 1,000 persons per year. What we identified is that there is a correlation between those health disparity zip codes and the residents in those zip codes have frequent ED visits, are also the zip codes where we had the most transports per 1,000 persons per year, and then also had the highest rate of calls to the Nurse Health Line and had the highest rate of alternative destinations. This is a very exciting result because we're targeting our interventions about the patients who are benefiting from these navigation services the most. We've analyzed our data to prepare for sustainability by program and by payer. And what this bar chart indicates is that the single largest savings were generated for the Nevada Medicaid program, and the single largest savings were generated by the Nurse Health Line. And what we have discovered is that the ease of availability of a non-emergency number and the connection between all three of our interventions, alternative destinations, Nurse Health Line, and community paramedic, with local community resources, local clinics and urgent care centers, connected with our Nevada Medicaid and our largest commercial insurer, Hometown Health, is generating continued program success in the AAA. This shows another way of looking at the ratio of savings by the Nurse Health Line generated 60% of total program savings. As a Healthcare Innovation Awardee, we were required to submit data to an independent evaluator whose name is RTI International. They issued annual reports over the last 3 years, and their final report was issued in August of 2017, just a couple of months ago. I have here on the slides the link to the CMS Innovation Center and then also the specific link to RTI's independent evaluation. It is a 1,000-page report. It includes grant-specific data on 24 grant programs that they put in a grouping called Community Resource Planning, Prevention, and Monitoring. So I'm going to give you some highlights of the independent evaluation of Remsa's 3 interventions. And I will also share with you how Remsa stacked up. How did we compare to those other 24 programs? So the average savings for the community paramedic 30-day hospital readmission avoidance was $2,520 per participant per quarter. They did find an average quarterly decline in spending, and they identified significant reductions in inpatient admissions. This is all based on Medicare beneficiaries. Our 3 grant interventions were available to all payers and the uninsured. The RTI independent evaluation is based on Medicare beneficiaries and Medicare claims data. And the RTI found that these findings were consistent with our innovation program goals. So in other words, we accomplished what we said we would accomplish. In the alternative destinations intervention, the savings were over $2,000 per participant per quarter, and they did find an average quarterly decline in spending. Both in the alternative destination and community paramedic intervention, we had a relatively smaller sample size so that the confidence intervals were not as high as desired, in part because of the small sample size. But nonetheless, they still found data to support that the interventions generated savings. They validated that we successfully diverted over 1,500 911 callers to a more appropriate facility. They identified that fewer ED visits occurred in the corresponding quarter of an alternative destination. And once again, these findings were consistent with the goals of our innovation. In the Nurse Health Line, once again, they measured savings. In this case, they found an average quarterly impact on spending was not statistically significant and was a slight increase. They attributed the increase in inpatient admissions to the fact that we actually advertised the Nurse Health Line to assist patients in navigating to the correct level of care. So there was a medical event that prompted the beneficiary to call the Nurse Health Line, suggesting that the Nurse Health Line encouraged individuals who needed care to get the care. In fact, we do measure the difference between what the caller intended to do before they called the Nurse Health Line to what the caller actually, what the recommended level of care is. And yes, we made follow-up phone calls in the first year or two of our intervention, identifying whether or not the caller followed our instructions. So we tracked patients all the way through the process. RTI found that these findings were consistent with innovation program goals. We fared extremely well in a cross-comparison between Remsa's 3 interventions with the other 24 programs in that group. We were one of 5 awardees out of 24, so there were 5 out of 24, and we were one of the 5 that showed significant reductions in spending. We were one of 7 awardees out of 24 to notably reduce utilization, consistent with the design of our program, and we were highlighted in our path to implementation effectiveness and sustainability. They ranked the programs based on implementation and sustainability, and we ranked high in those categories. The reason that last piece is important is that not all innovations are the same. You can have a very well-designed innovation, but if the execution is poor or misses its mark, then there is not an effective innovation. So we were measured in what are called dose and reach and effectiveness. And what that means is, did we actually reach the patient populations that we were targeting? For those of you that are interested in that level of detail, that's some of the detail that is in the 90-page report on Remsa's grant. So one of the most important overall aims, our aim statement was to increase access to the appropriate level of care by offering alternative pathways, by navigating patients using alternative pathways of care. Throughout our program, we measured what are called priority 3 transports to the ED. So those are the 911 calls that are presumptively classified as a non-life-threatening non-emergency, or priority 3. And what this chart out of the RTI report shows is that as a percentage of total ground emergency transports to the ED, the ratio of priority 3 trended down over time. This is a very significant finding that was also aligned with our theory of change. And it also is a way of measuring all 3 interventions' impact together, not just individually, as I mentioned previously, but the impact together. I also want to mention that I've put the figure number and the page number on these 2 charts. So this is figure 26 on page 80, so that you can look at the narrative and study the chart yourself. So the next chart is also out of the RTI report. So these 2 charts are both out of the RTI report. This is the weighted average quarterly Medicare spending per participant. So on the left-hand column, you see all 24 grant programs. And the 24 grant programs are arrayed on this chart to show their sample size and their p-value for you statisticians out there, and then their range of weighted average quarterly Medicare spending per participant. The red arrow on the far left shows Remsa's 3 programs, and the red arrow in the center shows Remsa's average quarterly spend. And by arraying this data in this format, you can see how Remsa's programs compared very favorably to the other 24 programs. And again, had weighted average reduction in quarterly Medicare spending per participant. So one of the most important aspects of launching a program is sustaining it. And there are 2 aspects of that. How do you create change and then sustain the change? And how do you generate funding so that you are reimbursed for these new services? Really what we are doing is we're challenging the healthcare status quo. And taking aim and building the evidence base is probably the single most important first step. We also invested an enormous amount of human and financial resources in what we like to call converting stakeholders into partners. And those 2 steps, in addition to these independently validated outcomes, are how we are creating and sustaining system-wide change. A huge thank you to the partners throughout our community, crossing healthcare sector, our community, our fire departments, our state and local regulators, community groups, numerous data and evaluation partners, and I want to not only thank RTI International, Health Insight, who is our regional quality improvement organization, and CMS Innovation Center, but University of Nevada, Reno School of Community Health Sciences, Dr. Trudy Larson and Dr. Wei Yang contributed, and graduate student Chris Dugan and our data team contributed enormously to how we measured and evaluated our programs. And as you know, in our white paper, we're also highlighting our data partners, First Watch, Priority Solutions, and Zoll. Just some examples of the engagement in our community. This is our federally qualified healthcare clinic, Northern Nevada Hopes, one of 2. The other is Community Health Alliance. And their capacity needed to grow their ability to have us navigate patients to those 2 federally qualified healthcare clinics needed to grow during the time of this intervention. We had enormous engagement with our community, front page article in our local paper. We did a pre-program awareness survey prior to launch of the Nurse Healthline and post-program awareness survey and found significant increase in the knowledge about the Remsa Nurse Healthline specifically. And we ran television ads that stated, there's one reason to dial 911, an emergency, but there are hundreds of reasons of dialing the Remsa Nurse Healthline. Our engagement at the federal, state, and local level is critical. This is Senator Dean Heller with Community Paramedic Ryan Ramsdell doing a community paramedic visit. This is Governor Brian Sandoval with a outstanding partnership between hospital-based, fire department-based, and private nonprofit-based EMS agencies in the state of Nevada. Governor Sandoval is signing our community paramedic legislation in 2016. And this is members of our Reno City Council and our Washoe County Commission, our UNR measurement partner, and Renown Health in announcing our sustainability plan and our partnership plan. And of course, we've also been featured in USA Today and Kaiser Health News. So before I open it up to questions, I'm going to highlight how important sustainability is and the steps that we took to achieve system-wide change. These are the 4 components of our sustainability plan. So heavy emphasis first on analysis and planning, which includes building the evidence-based. As you know, healthcare is moving from volume to value, and so identifying the value proposition and documenting your value proposition to your community, to your patients, and most importantly now to the payers is the essential activity there. I cannot emphasize enough how much community outreach we accomplished to achieve improved stakeholder knowledge of our programs. We are now in the major emphasis in the last 2 components here. The business development, classic business development activities to secure contracts with new sources of revenue, and public policy work. So in addition to signing the community paramedic legislation, in the summer of 2016, Nevada Medicaid approved CPT codes for community paramedic visits and also approved payment for transport to alternative destinations. Later, I have a link on a slide to show you if you want to look up Nevada's statute, regulations, and Medicaid payment policy. So while I indicated to you that we had a 7% return on investment over 4 years, in grant year number 4, the last year of our grant year, when our volumes were up, some of our startup costs were completed, we had an 84% return on investment across all 3 interventions. So that is year 4 grant expenditures over year 4 grant savings. So where is Remsa in gaining reimbursement for all 3 of our interventions? I would say we're about the 60% mark, and I'm only going to highlight on this today. If interested, this might be a great topic for a future webinar. But as I indicated, Nevada Medicaid is paying now for 2 of the 3 interventions, and we are currently in negotiations with the Nevada Medicaid managed care providers for the Remsa Nurse Healthline. We have contracts with clinical partners, which would be hospitals and medical groups, who in some cases are paying directly for community paramedic services. We have a contract with our local accountable care organization where some Medicare managed care patients and also commercial insured managed care patients are in that population. We have a contract with our largest local commercial insurer, Hometown Health, covering all 3 interventions: alternative destinations, community paramedic, and nurse healthline. And in fact, the nurse healthline, we have replaced 2, and we're working on a 3rd national call center or local call center. As we all know, there still is not Medicare fee-for-service reimbursement for any of these 3 interventions. I know that the American Ambulance Association, the NAEMT, the state EMS officials, and other national groups have focused efforts to use the outcomes from the handful of programs that have published their outcomes to generate Medicare reimbursement. And that's work that is critically important for all programs as we move forward. However, Medicare managed care, to the extent that you have a managed care program with those commercial insurers, we are receiving reimbursement for Medicare managed care. And because some of our services are available still to the uninsured, like the Nurse Healthline, we're beginning to reach out to local foundations and nonprofits to help fund especially the Nurse Healthline services. We had very important principles as we launched our grant, and this table was created in year 1 and remains important principles to this day. We never deny access to emergency services at any time. So patients are required to have informed consent across all 3 interventions. And if a patient demands to go to the emergency department or asks or thinks it's important, then that's the service that they get. So prudent layperson definition of emergency is important. But as I hopefully pointed out today, our programs are integrated, they're stakeholder focused, they're payer aligned, and we have significant new health information technologies and exchange of patient records and data real time. And of course, the fact that the programs are evidence-based are how we create permanent change. So I'm kind of coming to the last few slides before I turn it back over to Zach for some questions. Here are the links to the independent evaluation, the Nevada Medicaid Division of Healthcare Financing and Policy for the Medicaid CPT codes and Medicaid alternative destination policies. Of course, the Institute of Healthcare Improvement is an enormously wonderful resource for any organization that is engaging in healthcare improvement initiative. And the National Association of EMTs has a great page on their website that has a lot of information, as you all probably already know, about other mobile integrated healthcare programs. Here is Remsa-specific information. If you want more information about Remsa's community health programs, here is our email where we're beginning the process of providing additional information. As we mentioned, here is the link to the white paper. And new today, our team has discussed hosting a 2-day workshop in Reno on implementation of our community health programs. We're looking at dates in March or April of 2018, and if you're interested in attending a Reno-based workshop, you can send us an email. So I really want to say a huge thank you to the Remsa team. And that thank you includes our CEO, Dean Dow, our Medical Director, Brad Lee, the Director of our Community Health Programs, Elaine Messerly, all of our community paramedics, and all of our nurse navigators. This is Ryan Ramsdell, Katrina Travis, and Jake Beck, one of our original 3 community paramedics. I also want to thank you again, our technology partners, Zoll, Priority Solutions, and First Watch. And also, again, thank University of Nevada, Reno, School of Community Health Sciences, who is our measurement partner. On the very first day of our community paramedic program, one of our community paramedics was at a local hospital recruiting patients to be referred into our congestive heart failure program. and there was a lady outside the hospital who was in a wheelchair who had a sign, and on the front of the sign it said "Sustainable Safe Discharge," and on the back of the sign it said "Stop Patient Dumping." So one of the things that our team always focuses on is that these programs are about serving our patients, and how can we redesign our EMS system and integrate with the rest of the healthcare delivery system to help our patients solve their medical, mental, social, and life care problems. So thank you today for the opportunity to share our outcomes with you. I'm going to turn it back over to Zach for questions.
Thank you, Brenda. So first question we've got here is, how do you track your metrics during the course of the grant? Did you have automated reporting, pulling data from all these different sources? Was it done manually?
Our data was thank you for the question. How did we track our data through the grant? Well, first of all, we were required to develop what was called a measurement strategy. So we had 3 interventions with 7 or 8 measures for each intervention, and wrap-up measures across all 3 interventions, which totaled 28 measures where data was collected on a monthly basis in run charts. I showed you an example of some of those run charts. Initially, they were collected manually, and we had a full-time data coordinator, Patrick Ruther, one of our community paramedics. And throughout the grant period, we converted those measures we automated those measures with the assistance of First Watch. So manually, for measurement strategy across all quality domains, calculated by hand initially, automated, and reviewed and augmented by University of Nevada, Reno.
Great, thank you. We have some more audience questions here. Has or had the nurse triage line volume increased as knowledge of the service increased within the public?
So when we did the initial community outreach about the nurse health line, we ran 30-second public safety announcements. We did banner ads, and we distributed 25,000 nurse health line cards. Over 4 months, we went from 0 nurse health line calls to 2,000 calls per month. We predicted 250 calls, so it was 10 times more demand than we projected. So we actually had to hire more nurses. We have steadily received 2,000 calls per month, anywhere from about 1,800 to about 2,800 calls per month for the entire 5 years, and the call response has been steady. And we, in fact, also are serving 13 rural and frontier counties throughout northern Nevada. So the call volume has stayed steady.
Great. What was the ROI specifically for the nurse line?
So the return on investment, so for the return on investment for each intervention now is based on the prices that we negotiate with insurers. So the return on investment varies depending on which customer it is, what their clinical goals are, and what the price of the service. So, and I would also point out that even though there was a slight, and so today I presented the return on investment during the period of the grant program. So even though RTI showed an increase in spending of $245 per member per quarter, that is only less than 1/4 of an ED visit. So the increase in spending per member per quarter is less than 1 ED visit. So we're working presently to use the RTI data to calculate a intervention-specific ROI, but again, it's based on what each payer pays.
Mm-hmm. And what was the biggest obstacle or hurdle that you overcame in the implementation of the program?
So that's a great question. As many mobile integrated healthcare programs have found across the country, changing the expectations and behaviors of the public, of individual patients, of our own EMTs and paramedics, of the receiving facility personnel, and the payers, basically I'm saying all of the stakeholders, takes time. So there was opposition to certain programs. There was enormous opposition to expanded scope for a paramedic. So therefore, we did not expand the scope of a paramedic. There was opposition to not transporting every patient to the ED. So we focused on conservative protocols with alternative destination, and we did not do treat and release. We did not do treat and refer, and we did not do treat and no transport. We did transport to alternative destination. So opposition is a major obstacle, and the solution is that we worked with stakeholders to tailor our interventions in a manner that was a win-win for all of those stakeholders.
Great, thank you. A question from the audience: how do you get the caller's informed consent to transfer them to the nurse, or is that automatic on Omega level calls? Excuse me.
So there is significant case law and statutory support around the United States for nurse helpline, nurse hotline, nurse advice. So the script of the nurse includes patient consent. So she asks for consent on the phone, and it is on a recorded line. So we are documenting consent because it's on a recorded line.
Great. Another question here. There was not much discussed about mental health alternative destinations. Who decided which facility the patient went to, and did the patient have to be medically cleared before going to a psych facility?
So the issue of medical clearance was addressed in the protocols with Remsa's medical director and the receiving facility's medical director. And so that issue evolved over time as the capacity of the receiving mental health hospital changed, their ability, their staffing, and then in the first year we only had one mental health facility that would accept patients, and now we have 3 and possibly a 4th coming on board. So it is specific to your local EMS system protocols, scope, and the requirements of the receiving facilities.
Fantastic. Does your nurse triage line also arrange patient transport to the local facility? And if so, how and what resources were used for transport?
So the Nurse Health Line has a list of over 2,000 resources in what is called the Directory of Services. So the obvious navigation are to alternative clinical care. But yes, they can refer to social services, community services, rent assistance, our statewide 211 number, which also has a very large referral network. And when needed, we can facilitate and refer to transport to alternative types of transportation. We are not coordinating that directly, but we do refer.
Great. How has your data from the Nurse Helpline been compared to commercially available Nurse Helpline data from large payers such as Blue Cross Blue Shield? Why would they want to drop their Nurse Helpline for yours?
So that's really an outstanding question that is something that the Remsa approach, which was not only turning on Omega, but also making a broadly available community resource available, we are still working on. I can tell you that we have replaced 2 nurse advice lines, and we're working on 2 more. where our transfer rate to the ED and to 911 is significantly lower than the insurer's current call center.
Mm-hmm.
So we have identified that the EC&S protocols and that stands for Emergency Care Nurse System, and the triage function is very precise and optimal. And so that negotiating that value proposition when they have a national call center is a challenge. We believe that locally connected services have merit, and so we're going to continue to work on that strategy. I will tell you that not all insurances provide a call line. The uninsured does not have access to nurse triage. Medicaid and Medicare fee-for-service do not. So there still is a very large patient population that benefits from this. So this is a major policy challenge for Remsa and us nationally if this intervention becomes part of our future.
Great. How is the directory of services used by the nurse helpline maintained?
All of the nurse navigators do it kind of real time, and so if they're not, and in fact, we spent about a month building it 4 years ago, and then over time it just is maintained, and every time we identify a resource, it's added. There's actually a lot more online activity being performed by the nurses because the types of resources are changing constantly. So it's done by the nurse navigators directly themselves. And they're frankly their own personal knowledge of the community, which, by the way, is another benefit of a local nurse health line connected with the EMS system versus a national call center that is not as in touch with its community.
Great. So did you develop the curriculum for the paramedics yourselves, and then how did you determine how much clinical was needed, if so?
So the Remsa curriculum was developed by the Remsa team. Diane Rolfs, who was our Director of Education at the time, Dr. Bradley, and Elaine Messerly. Dr. Trudy Larson at the University of Nevada, Reno, and as I mentioned, she is the Dean of the School of Community Health Sciences and a physician herself, designed the curriculum, taught the curriculum, did competency testing, and again, also patient satisfaction scores. We had a longer course in the first round, 500 hours. We reduced it to 150 hours. An example of a major addition to the paramedics' clinical knowledge is the process of motivational interviewing. And again, we're very confident with our training program because of that competency testing that UNR helped us with.
Great. What is the size of the service area that you guys are working with, and did you limit the catchment area where you would enter patients into the community medical program?
Great question. We started with Washoe County because that is where the Remsa ambulance transport franchise is focused. Washoe County, Nevada. We have about 500,000 residents in Washoe County, Nevada, and about 300,000 in the city of Reno. We have now expanded to neighboring suburban communities, and we have a strategy of collaborating with all of the local, mostly fire departments, although some volunteer and hospital-based in surrounding communities. So we're collaborating with our region to expand the scale to replicate our program throughout the region. And the Nurse Healthline's reach is enormous, covering the entire northern Nevada region. Our Nurse Healthline nurses are certified in Nevada and California because the northeastern Lake Tahoe region fits in our medical trade area. So that intervention extends into California. The rules for community paramedicine are different in California, so presently our community paramedics do not serve in California.
Great. You stated that 60% of the savings resulted from the nurse helpline, but the stats show an increase in costs on slide 27. Can you drill down on that a bit?
Great question. The RTI report compared spending between, as I mentioned, for each of the 3 interventions. Let me describe how the RTI report worked. They had a minimum of 100 Medicare beneficiaries that were enrolled in the intervention. They created a comparison group of matched pairs of similar demographics, age, comorbidities, socioeconomics, etc. So that's how the RTI report had a comparison. We also measured the avoided events. How many ED visits did we avoid? We also measured our transfer rate. How often did we transfer a caller back to the 911 system? So our return on investment on the nurse helpline is more broad than what the RTI reported. And it relates to what was the patient intending to do before they called the nurse helpline, what did the nurse recommend, and also I indicated we made follow-up phone calls on every patient we could get a hold of for the first year. And we have data on how often the patient actually followed our advice. So the drill down is we have more data points that show the value proposition for nurse triage.
Great, thank you. And we've got just a few more questions here. How many community paramedics do you employ?
We started with training 10 community paramedics. We had, through attrition, community paramedics becoming paramedic supervisors and joining our care flight division. We had some attrition, so we've had a total of 3 community paramedic programs, and we've trained probably a total of almost 20 community paramedics. We're scheduling another community paramedic program after the first of the year, again, because of attrition. Our volume of referrals has gone down significantly, so we have fewer we provide 7-day-a-week community paramedic coverage and on-call at night. And because we have no way of funding community paramedic visits to Medicare fee-for-service, our volume of paramedic referrals for the 30-day readmission has gone down. So at any given time, we might have 2 or 3 community paramedics assigned at any given time.
Great, thank you. And then, do you think that this program or this strategy will work for a critical care transport team?
Can you say that again?
Do you think this will work for a critical care transport team?
So, transporting patients in a critical care transport ambulance is really, sort of part of the traditional interfacility transport service line. We do have a CCT service line. All of our community paramedics now are cross-trained in our specialty care transport training program. So there is a great synergy between those 2 service lines.
Fantastic. And we have a question about, will audience members be able to get a copy of the Remsa grants report?
So the Remsa Community Health Program's white paper is available online. You just go to the website that was on the last page of my slide. I understand from the Red Flash team that an email is also going out to all registered participants with that link so that you can download the white paper. Also, the link to the RTI independent evaluation is in the white paper and also in my slides.
Fantastic. Excuse me. There is a national effort, and we'll make this one the last question, I think. There's a national effort to create a standardized set of knowledge and skill that defines a community paramedic. Would Remsa consider adopting a curriculum that will contribute to this effort, as it will go a long way to creating a reimbursement structure for community paramedic activity?
Absolutely. So it is really important, as I mentioned, that there are lots of pioneers in mobile integrated healthcare, which include our friends Dan Swayze, Matt Zavadsky, Gary Wingrove, Jonathan Washko, the AMR team. And as these innovations produce data and generate lessons learned, we're going to identify the most successful ways of delivering these services. So it's really important that the innovation continues, but then over time, as the various programs publish their data, we'll learn where we may come into a more standardized area. So there's a healthy balance between not standardizing too soon and encouraging innovation, and also understanding that the evidence will help us know what the process moving forward is. Now, having said that, there will probably be only one Medicare fee-for-service solution. So it's one of the reasons that we wanted to share our self-monitoring data and our independent evaluation data for the purpose of collaborating with with other mobile integrated healthcare programs and the national associations as we work towards Medicare fee-for-service reimbursement. And I think we're very excited to work with all of the pioneers in the industry to make that happen.
All right, thank you very much, and thank you for taking the time today to speak with us. Brenda, I'll let you sort of have the closing words here.
So again, thank you very much to EMS1. Thank you to the Red Flash Group, and especially thank you to the Remsa team, the entire Remsa CareFlight family, for their tenacity and their hard work and their staying power. And we look forward to working with all of the mobile integrated healthcare programs across the country to move these balls forward. So thank you again.
All right, fantastic. Thank you, everyone, and have a great day.